Okay, good morning, good afternoon, good evening. Welcome, clinical problem solvers. ALA is here today to solve our monthly case. And yeah, David, I think I made you a co-host. So we are really happy and excited to be here today. Blessed as always. And Kashia is going to be helping us with the teaching points. David's going to be helping with describing. So very thankful to them. And then we have Ganesh, who's going to be our case presenter. Ganesh, you want to sort of tell us a little bit about yourself, and then we can get the whiteboard up and go ahead and get started.
Yeah. So thank you for giving me this opportunity. Myself, Kanishk, I'm an international medical graduate from India. Currently, I'm in US doing my rotation. So thereby, I'm presenting today a case, and I titled that case as a painful puzzle, unraveling the mysteries of myalgias and abscesses. So let's dive into that.
I feel like Kirtan has rubbed off on us so much, and I'm sure he's monitoring the whiteboard remotely right now somewhere. But shout out to Kirtan, who is just an amazing person that has influenced so many people. But yeah, let's go ahead and get started with the first aliquot.
So this is a 63-year-old gentleman who presents with diffuse myalgias, arthralgias, and chills, and for several weeks. The arthralgia was most prominent in her wrists and her knees, and they had progressed to the point that now he had unable to extend those wrists and fingers because of extreme pain. He did complain of weakness in lower extremities, but he did not complain of any fevers, night sweats, hematuria, cough, dyspnea, no abdominal pain, bowel, or bladder dysfunction.
Okay, Ganesh, and that's where you'd like us to go ahead and get started?
Yes. So this is my first aliquot.
Excellent. Wow, what an aliquot it was. Austin, you want to go ahead and get started, or do you want me to go first?
Lead the way. You're the older brother.
Okay. Well, wow, very interesting constellation of symptoms. So I guess the way my mind initially translated this is a middle-aged man with sort of a subacute, what I'm going to call an inflammatory syndrome involving the sort of musculoskeletal system. And I think it's, right now the symptoms in and of themselves are a little bit peculiar. Most people that have arthralgias and they're more chronic tend to be, or subacute chronic tend to be on more of the autoimmune phenomenon, but we're still in this potentially acute phase where it's hard to know exactly what to make of this. And it sounds like the distribution is mostly in the wrists and the small joints, if I'm remembering what Connor said correctly, the wrists and the hands. Is that right?
Wrist and the hand, as well as her knee, in his knees.
In his knees as well.
Yeah, he was unable to extend, and he was unable to ambulate. He was bedridden from last 2 days. Earlier he was having a pain. From last 2 days it becomes so severe that he could not ambulate and could not pick up the food to eat. So that grade of severity was his pain.
Wow. Okay. So I think there's definitely some sort of inflammatory process localized seemingly in the musculoskeletal system. And I think what we need to sort of further investigate, is this muscular? Is this articular? Is this periarticular? And the exam will be very, very helpful for that to make additional progress. And so, although the patient said he wasn't febrile with the chills and with just how severe the pain has become, I certainly feel like I'm getting an inflammatory component. It's just going to be where exactly we're going to be localizing this. And in the clinical problem solvers, we can use our I-made mnemonic to sort of think about etiologies of inflammation. But I think if I'm going to be fully transparent, when I take care of patients like this and they tell me that they have joint pain, I get a brief history, but I'm just going to the joints. I'm taking a look. I'm seeing what they look like. Are they red? Are they swollen? Where exactly are they tender? Which joints are involved? Is it with active range of motion? Is it passive range of motion? What is their functional baseline like? Is there synovitis on exam? Is there asymmetry? Is it symmetrical? And I think there's so many things that come to mind where, history is incredibly important, but sometimes for MSK complaints like this, sometimes going to the exam and then building your history off of that can be extremely helpful. As you can imagine, if you had, a monoarticular arthritis and their joint was very red and swollen, the way that you might think about things or ask questions may be totally different if the patient has, diffuse arthralgias, right? Or diffuse arthritis, if that's I'm going to translate into inflammation. So I think at this point, I'll be interested to get more history to see if there's preceding illness, to see if there's a prior history of joint pain, to get more of the background of the patient, any recent travel, Any other systemic associated symptoms, or is this a syndrome that's primarily centered in the musculoskeletal system? And from there, just defining the immune status. So Austin and I always joke to ourselves that like we need to think about that earlier. So I think trying to risk stratify that earlier will be extremely helpful as far as building our differential diagnosis. But I guess right now I'm just thinking of an inflammatory musculoskeletal process, seemingly more subacute, but hard to know if there's more of an acute or a chronic tail to this. And I think the exam will be really helpful for us to sort of further define our problem, as Robbie likes to say, and then we can build a differential from that. But those are my initial thoughts. Austin, I'd love to hear what you're thinking here as well.
Really nothing left to add. I think it's just building our problem representation so far. It's kind of a diffuse, subacute, progressive, painful, polyarthralgia, which maybe will become polyarthritis. I always struggle when, with the polyarthritis or myalgias, like when there's a joint component, there's a muscle component, which one should we go down first? And I think to me, it just speaks to the diffuse nature of the problem. And so, Robbie likes to teach us about, if the problem is diffuse, what is diffuse, and think of those things. So there's the bones, there's the muscles, there's the vessels that connect them. And so when I see such a prominent bone and, maybe muscle issue together, it does make me wonder about the vessels a little bit, or the nerves, but I think it's a little bit too premature to go through. And I really agree with everything that you already outlined. So let's hear more.
So let's go for Alec 2. So he did not have any significant past medical history. He did not do any drugs, no smoking, no alcohol. But he did an hiking trip 2 weeks ago, and he had multiple tick bites. So, and on examination, the temperature was 100.4 with a heart rate of 90 beats per minute. The respiratory rate was 23 breaths per minute with SpO2 96 on room air. Patient was started on IV fluids, Vanco and Zosyn. And on systemic examination, he was alert, oriented to time, place, and person. On CVS examination, S1, S2 were present, normal rate and regular rhythm, normal pulses, pulmonary bilateral breath sounds were present. Musculoskeletal system did show some significant findings, with right elbow swelling was present, left elbow swelling was present, right knee swelling present, tenderness was there. On left knee, erythema, swelling, and tenderness was there. Skin was warm and dry. Capillary was less than 2 seconds, and there were no neurological focal deficits were present.
Wow. Okay. Very good. And sorry, I missed the blood pressure. What was the blood pressure?
Blood pressure was 120/80 was normal.
Okay, 120/80. Perfect. Okay, yeah. So we're kind of getting the background history, and I think, as Alec alluded to, we were basically concerned about inflammation, and so we were taking a history with wondering if we were going to see any signal for inflammation, and maybe we found some in this hiking trip where the patient seemed to have been recognized that had been bitten by multiple ticks. And so now, is this related? Is this not? We'll find out. But I think so far in a 63-year-old with no medical history, and whether that's related to just limited access to care, or if this is truly a reflection that this patient has no underlying medical conditions, I think that'll inform us as to what the probability is that this is related or not to the patient's syndrome. Okay, sorry about that. The cat was getting in the way and then accidentally turned on some music. Okay. Kind of going back, I think if we just take everything at face value, like I'm going to ignore the tick bites for now, because, oftentimes people won't notice that they had a tick bite, or maybe it's true to unrelated. So if I take it at face value, I see the patient's vital signs, right off the bat, I'm not terribly concerned about the patient, given we don't think they're in an immunocompromised state based off the history. But then again, when you kind of look in a little bit closer, the patient has, a borderline fever. They're mildly tachypnic, depending on what cutoff you use, and the oxygen saturation is slightly lower than they would expect. So just given, again, maybe the diffuse nature of the syndrome that we're invoking, I'm going to have to kind of think about the lungs more in depth, really listen closely with my stethoscope, or since our great leader doesn't even carry a stethoscope anymore, then we will just think about the chest imaging. And so I think that's something that I'll be keeping an eye on, just because we are thinking about a diffuse process that's going on. As far as the remainder of the exam, really it's most notable for the musculoskeletal exam. And I think we are getting a sign that, well, we weren't told exactly where the swelling was, but I think we're confirming that this person has truly an arthritis. So they have polyarthritis. It seems to be affecting the large joints. And so we could start to build a differential from that. Alec kind of already alluded to that, so I won't kind of belabor that. But now let's go back and let's say, hey, let's talk about these tick bites and what do ticks carry. And assuming that the patient went on a hiking trip kind of in the Ohio general area, then of course we could worry about Lyme disease, though that might be a little bit far west depending on exactly where the patient was. But I think is it possible to invoke Lyme? Can Lyme cause polyarthritis? It can. Do I associate it with this otherwise kind of diffuse debilitating syndrome? I don't, but I think this is just a knowledge gap for me, because I've actually never seen a case of Lyme disease or any tick-borne related illness, same for typhus in real life. So I think that's a learning point for me. What other things could you think of causing, what other tick-related illnesses could fit with this clinical syndrome? I think of rickettsia. We haven't heard of a rash. Certainly there are forms of rickettsia that you might miss the rash or it's not there. So that will be a consideration, and it could be consistent with just how debilitated this patient is with their symptoms. And we thought about ticks, but maybe this patient was bitten by other insects or parasites, and certainly the diffuse syndrome could make us think of some of the like viral causes, but typically we wouldn't see those in our neck of the woods, like in the United States, but those would be considerations as well. So yeah, those are my general thoughts. I feel like it really just confirms our hypotheses. Doesn't help me make too much progress, except for thinking about, hey, is there any other systemic signature to this condition beyond the joints? And so I would be looking to the lungs. I'd be looking to the urine as well. But Alec, what other thoughts do you have?
No, excellent, Austin. I loved your initial thoughts and breaking it down between thinking about the case without the tick bite, and then thinking about it with the tick bite. And I think that's important to recognize that it could just be true and unrelated. And I guess I wanted to clarify, I did happen to miss the temperature. Contact, do you mind repeating it for me, what the temperature was?
It was 100.4.
Okay, excellent. So yeah, I think the vitals and then particularly the physical exam really point towards inflammation. And the patient is, by our sort of United States definition, febrile at 100.4, but his heart rate is shockingly normal, right? Usually for every degree of temperature, you goes up roughly, your heart rate should go up by 8 points as well. So we don't get a history that the patient's on a beta blocker that was a little bit older, perhaps has some conduction disease, and the baseline heart rate is a little bit lower. So, anytime you see fever with a normal heart rate, that's something called the Faget sign. And sometimes it can be indicative of intracellular organisms, the salmonella, gonorrhea, and then frequently the tick-borne illnesses can cause that as well. It's hard to say. The temperature is like technically mildly elevated, but I don't know if it's enough to cause significant tachycardia. But it's just something that I was tracking and that struck me. And then indeed, the joints are very swollen, very tender, seemingly the large joints. Although in history, it seems like the patient was able to bend his legs and to move his hands. I would be interested to see if there was any small joint involvement and then feeling for synovitis. And then this swelling, I'm kind of wondering, is there an effusion there? Is it just diffusely swollen? How red are they? Seems like one knee seems to be a little bit worse than the other. And then I also, at the same time, in addition to thinking about other things on exam, for the abdominal exam, we didn't get that. But if we're considering tick-borne illnesses, assessing for hepatosplenomegaly might be something that potentially be worthwhile, though it is specific but not sensitive on the exam. And then I would also love to know if the patient had any rashes. I'd love to visualize, if we've seen the tick bites, what they look like. Did the patient notice any rashes previously? And that might help us corroborate things as well. But I think because there's multiple joints involved, the chance that this is going to be, pyogenic arthritis is probably a little bit unlikely. And then we're sort of getting to the oligoarticular, polyarticular realm. But I think something that really strikes me is it sounds like, this patient was healthy enough to be hiking around, right? And now just over a couple of weeks cannot even get out of bed. And I just think that tells you how absolutely debilitating this illness is for this patient. And whatever is causing this inflammatory oligoarticular syndrome, whether we're going to call this acute or subacute, I think the rapidity of it with a normal background makes me prioritize infection just a little bit more. And it's really hard not to think about ticks. And then, Kodak, if you don't mind clarifying, where was the patient located when he was doing his hiking?
He was located in Maryland.
In Maryland, okay. So we're over there on the East Coast. I've never practiced medicine there, so I think my own script is lacking. But in addition to the ticks that Austin also had mentioned, definitely thinking about ehrlichiosis, anaplasmosis would be other things to be thinking about as well. And then, but babesiosis as well. And then depending on the time of year and some other clinical symptoms that the patient might be having, don't typically causing as much diffuse joint pain, but something to consider. And then, if the patient did travel at all recently, although it sounds like that wasn't the case, with global warming, and shout out to Leah who gave a great talk on this as well. But there's so many organisms that previously were isolated to certain parts of the United States or parts of the world that are now sort of conglomerating, and so our infectious diseases are expanding as well. So I think at this point, I think the labs are going to be telling, are there systemic signs, are there signs of a systemic disease, particularly a tick-borne illness? Is there leukopenia? Is there thrombocytopenia? Are the liver chemistries elevated? Is the sodium low? Does the patient have kidney injury? And other things that we'd be looking for. I think as well, I know the patient is inflamed, so I'm not sure that the inflammatory markers in itself would provide all that much value to me. But I would probably be considering imaging the joints, but to me, on a physical exam, if the patient has a swollen joint and has an effusion, we should tap it. And if we're getting other systemic signs where we may be able to avoid that, I think certainly it's possible. But if it's truly oligoarticular, the patient is 63, maybe determining other risk factors for the crystalline diseases, all I think is less likely in the situation is something that we can consider on the differential as well. That's non-infectious. But in this patient that seemingly is very, very ill, I think I would be looking towards the labs first. I'd be getting blood cultures. It sounds like the patient was started on vancomycin and ceftriaxone. I think with the history, I certainly would probably consider starting this patient on doxycycline as well. But I think also the labs will maybe give us some hints that exactly what's going on. And then, it's hard to pick up hepatosplenomegaly. It's hard to pick up lymphadenopathy on physical exam, and some of those things we pick up on imaging. So if there's a signature for inflammation in the liver or something going on with the bone marrow, we can investigate that a little bit further. But just sort of challenging myself to think about what I do next. And I think at this point, I'd probably be relying on our basic chemistries, the CBC, and then, considering whether or not we need to tap the joint. But Austin, before we hear more, I would love to know if you had any additional thoughts.
Nope.
Okay, Connor, take us away.
So let's go on aliquot 3 now with lab values. WBC was 21.8 with neutrophil of 89% and lymphocytes of 4%. Hemoglobin was 10.7, MCB of 90, platelets was 523, sodium was 135, potassium was 4.5, chloride was 101, carbon dioxide was 24 mmHg, BUN of 19, CRAT of 0.7, glucose of 130, total protein was 5.5, albumin was 2.2, bilirubin was 1.8, alkaline phosphatase was 145, AST was 64, ALT 188. Lyme serology antibody positive. On urine analysis, WBC were 100 high power field, RBC was 5 high power field, 1 plus protein, lactic acid was 3.2, and chest x-ray showed left lower lung ground glass opacity.
Wow, what an interesting set of additional data. Austin, maybe I'll just try and tackle the initial chemistries, and I'll leave the urine and the chest x-ray to you. But so patient is very inflamed, confirmed by the leukocytosis that's predominantly neutrophil predominant. And I think our sense was that this is potentially related to infection, and I think we'll continue to get iterative history in labs to try and prove that hypothesis, or this could just be an inflammatory response. I guess if my pretest probably for tick-borne illnesses was initially, moderate to high, And not that you can't have leukocytosis, but leukopenia is just more common. And so I guess I was a little bit surprised by that, in addition to the sort of relative thrombocytosis. So I'm not sort of dropping those off the differential, but just something to continue to think about. And then the BMP honestly isn't really all that remarkable to me. I would love to know what the patient's baseline creatinine is, if we have that, just to see if there's any aberrations there. But for a sort of otherwise healthy 63-year-old man, it doesn't seems to give me a lot of clues. The sodium is basically normal, and the glucose is only mildly elevated. But with the amount of cortisol and some sympathetic drive this patient has right now, I would expect the glucose to be a little bit elevated. I think the total protein and the albumin are low. The albumin, as many of you know, is a negative acute phase reactant. So anytime there's significant inflammation, it will go down. So that could be related to that. The bilirubin is mildly elevated. We don't have it fractionated. So I would love to know, with the anemia as well as this indirect, is it potentially direct? And I'm sort of leaning that it might be direct just with the liver chemistry test, where the ALT is significantly more elevated than the AST. I don't know what this patient's BMI is. I don't know what their habitus is. I don't know if they have any risk factors for underlying MASLD or steatotic liver disease. But, I'm going to assume that these abnormalities are acute. And, they're at the point where I don't know if the liver is a bystander here or this is a sign of signal. But I'm more inclined to think that it's potentially a bystander. But I think our additional infectious etiologies will dive into that a little bit further. And then we can decide when we're further investigating the patient whether or not some dedicated imaging, which is a right over quadrant ultrasound, at least to start, just to look for biliary ductal dilatation or any signs of hepatitis might be worthwhile. I think anytime that you have some liver chemistry test abnormalities, a subacute time course, and arthralgias, although I don't typically think about it quite so inflammatory, just thinking about the viral hepatitis would be something else that you wouldn't want to miss. So I would like to get some coags as well, just to be sure that the liver isn't going on as well. And let's see, the Lyme antibody serology. So I would be interested to know, is this an IgG? Is this an IgM? It sounds like the hiking isn't a new thing for the patient. So if it is an IgG, it's hard for me to know if this is a sign that the patient previously had an infection that he cleared on its own, or is this is a sign that he has an acute infection. I've never seen Lyme, so I don't really have a robust illness script. Usually you can't get some polyarthralgias and some fatigue and systemic symptoms, but I don't really think to this degree as I was expecting. There's no cardiac abnormalities. There's no other things that we recognize. So I'm not exactly sure what to make of that. And I think more information about, for me personally, would be reviewing the illness script for Lyme, how long ago he did the traveling, when the tick bite was, how the serology was obtained, is it IgG, is it IgM, are there better tests for Lyme, does the illness script fit? I guess for the little I know, it seems a little bit less consistent, but I would love to learn and to grow from that. And then, yeah, Austin, I'm really interested to see what you think of those labs and then what's going through your mind with the urine and the chest X-ray.
Yeah, really nice analysis. And, I really don't have too much to add. I agree that the leukocytosis is striking, and I'm not sure if that's signal at all to the underlying process here. It is neutrophilic predominant. So in that sense, it's sort of alluding back to the last time we discussed, I think that fits with the base rate. And maybe lowers our suspicion for some sort of funky inflammation. But I think if we take a step back and say we're worried about an infectious process, there seems to be a diffuse syndrome. So there seems to be some sort of external reason for infection. So as opposed to a commensal organism that is taking up shop in a place that it shouldn't, I think we can invoke the possibility of a virus, which there are certainly viruses that can cause prominent arthritis or arthralgias, but I'm not sure that the laboratory signature and the rest of the clinical presentation is consistent with that. So now we're really in the space of atypical bacterial infections, like the tick-borne, some of the tick-borne illnesses we've alluded to, and then more like toxic shock, but we're not really in that space right now. So I think we're square into this external organism causing an infection, which an organism, I have to say, infectious disease is a weakness for me. So I'm really happy to have a case to discuss through. So I think, we alluded to Lyme before. Lyme often from what I recall, the laboratory signature really isn't this prominent. So I would say that in and of itself, this outside of the arthralgias, I'm not sure that the clinical syndrome really fits with Lyme, but I'm happy to be wrong about that. But right now, I'm not really getting that sense is there. And so from that sense, just as you alluded to with the patient's like prior history of being an outdoorsman, then I'm going to sort of ignore the Lyme serologies right now, because even under the best of circumstances, they're difficult to interpret, which is why from a recent podcast that I heard, you just treat empirically most of the time, because it's just the benefits of doxy outweigh the risk for the most part. So now we moved into the sort of other findings that you didn't allude to. I agree with your interpretation about, there seems to be some signal in the liver. We have signs that there's not just based off of the history, but now with the platelets, that most likely this is at least a subacute, maybe more chronic process based off of the level of hemoglobin drop and then the thrombocytosis. Now we're seeing signal potentially in the lung, but also in the urine. And so the urine, if I wrote it down correctly, we seem to have some hematuria, we seem to have some pyuria, and we seem to have a small amount of proteinuria. So really we have an active urine sediment, if you will. And so Alec likes to call this sort of the liquid biopsy. So which of the organisms that we've invoked as tick-related illnesses can involve the lungs and involve the, or let's start with this first one, this one first. Start with involve the kidneys. You have to say, I don't have a robust perspective, in the cases that I've reviewed, rickettsia certainly can cause renal involvement. So that's definitely a consideration, and certainly can cause severe illness. So I will be going with that. I'm not sure the clinical syndrome fits with babesia or ehrlichiosis so far, and I'm not sure if those can cause, some of those can, like if severe illness can cause such a profound like systemic syndrome that you could get renal involvement, but I wouldn't expect this more inflammatory or pattern. So it's difficult to invoke that's there. So I'm kind of in the rickettsial space right now, but I just don't have a robust enough illness script for the rest of the organisms to really make progress. So Alec, if you have any comments. So then we move on to the lungs. And so the lung findings here, we were obviously a little bit concerned about it in the first place, just based off of the patient's vital signs. If we're trying to these tick-related bites, again, we're focusing on the ticks, but any sort of exposure to a bite of any insect, you can always have infections that travel with one another. So could we have multiple infectious organisms at play? I suppose as a consideration. Could it just be a sequela of the patient's illness? And now that this lung finding is, a community-acquired pneumonia, the time course, we'd have to really tease out if it's truly separate or not, because the time course would be long for that. The other thing with the progression and the more systemic illness and the thrombocytopenia and the association with rickettsial diseases and other kind of systemic inflammatory diseases is the possibility of DAH. It's not really diffuse, but it would definitely cross my mind, especially with the kidney finding as well, because we'd have to maybe invoke the possibility of like a pulmonary renal syndrome, though the normal creatinine is somewhat striking. This makes me wonder if this could represent more of like a tubulointerstitial process as opposed to something affecting the glomerulus in and of itself, or at least in isolation. So as far as how to make progress from here, I would probably, if we haven't already, I would definitely empirically treat the patient with doxycycline. I would maybe do some testing, a thick and a thin smear. I would do some more testing for the specific organisms that might fit this patient's presentation after I reviewed some illness scripts and the sort of infections that are arthropod infections that are unique to the area that the patient hiked through. I would probably get a CT scan of the patient's lungs to better clarify exactly what's happening, just because an X-ray is not enough at this point. And then I would trend the urinalysis and see what it looked like, watch the patient's creatinine and urine output. And if it persisted then, and we were having difficulty making progress, then probably I would pursue, think about, pursuing any other diagnostic test like a renal biopsy to see if we would need to make progress. But I think right now we have other pathways that we can go. But yeah, Alec, any additional thoughts before we pass it back?
No, that was excellent. I think it's just I'm struck by sort of the hecticness of the case. It's like you got a little bit of lung, you got a little bit of kidney, you got a little bit of liver, then you have the joints. I mean, the joints overall seem to be the primary center of the gravity, at least for the patient, but there seems to be multiple organs that seem to be involved. And I think, we've taken care of enough patients at this point where like a left lower lobe opacity on a chest x-ray, like, I don't know what to make of that. I did see it myself, right? And so I really agree with you. The patient isn't reporting any pulmonary symptoms, but I would imagine if your joints are hurting that bad, that may not be something that you're thinking about. But you really astutely picked up on the exam that a 93%, right, is not normal. So I would pursue that. And then honestly, I think with the liver chemistries and just the insensitivity of the ability to pick up hepatosplenomegaly and like how that might change your differential, I think just getting a CT scan of the abdomen may not be the most cost-effective way of care, but I think to sort of better look inside what's going on, I think may help me make initial diagnostic progress. I think as well, although the patient denies any past medical history, risk stratifying him further with an HIV, I think would be extremely helpful as well, just to be sure that we're not missing that and we're framing our patient in the correct way. Anytime I think about neutrophilic leukocytosis, multiple joints involved, I think he doesn't have the sort of concurrent cytopenias, but just, further tracking the inflammation and the anemia with a ferritin, and depending on how high it is, might influence our differential some, but is a little bit non-specific. I totally agree with getting the patient, blood cultures and then starting him on doxycycline in addition to the other antibiotics. I think is, a reasonable approach. And then the urine and those, liver chemistry abnormalities and everything. Like, I would love to know what the dipstick said for the blood. If there's 3+ blood and 5 RBCs, like could the patient have? I know the ALT is higher than the AST, but thinking about a CK involvement or thinking about the idea of hemolysis and how that could play in. And you're right. The asymmetry of the lung involvement and the lack of hypertension, at least at this point, I think we need to think about non-infectious etiologies at this point, not to be led astray, including pulmonary syndromes or other vasculitides. So I think a urine protein creatinine ratio would be good to start, trending the UA. And then we can decide how much of a deep dive we need to take into, that autoimmune branch point of things. But sort of the rapidity is just somewhat striking of like how the patient, like, it sounds like, if I remember correctly, just a few weeks ago, he was out hiking and now he can't even get out of bed. And that sort of is, hasn't escaped me quite yet. So, I think at this point, just getting additional imaging, clarifying what organ's involved, which one seems to be the center of gravity. If there's fluid to tap, would we do that? Trending the labs, trending the clinical picture, because a lot of times at this point with such hectic organ involvement, either things are going to get worse or things are going to get better, and something will be declaring itself. And time is frequently a good diagnostic test. Not that I'm hoping that the patient gets worse, but just to better define our clinical problem, what exactly that we're looking for. So I think it would be a good time to learn more. I were able to enough.
So we did a urine culture and a blood culture. It was MRSA positive, and on transthoracic echocardiography as well as esophageal echocardiography, normal ejection fraction and no vegetations were seen. A very interesting point was made here. We gave a patient a 2 dose of steroid, and on the following day, patient swelling was boom cleared. There was no swelling. Patient started to feed well, and patient started to ambulate. But on that evening, we did a detailed examination, and on flexion, adduction, and abduction of the patient complained of extreme pain and had guarding with movement. So this was Aliquid 4.
Wow. Okay. So the patient's blood and urine cultures were positive for MRSA. And then the decision, I guess somewhere in there, maybe before the culture report came back, the patient received some steroids and had dramatic improvement in their symptoms, but then later recurred, or later, like on examination, the patient felt better, but actually had pain when you kind of did range of motion of the joints. Is that correct?
Of the hip, yes. Only
of the hip.
He didn't have complaint in his knees. He didn't have complaint in his wrist, but yeah, he did complain in his hip when he did flexion, abduction, and adduction, and had a guarding movement there.
Okay, and on one hip or both hips?
On unilateral, on the right hip.
Right hip. Okay. All right. Wow.
These were not present on an initial presentation. It was just after we prescribed the steroid. Then it showed us.
Wow. Okay. Incredible. And I was, as Alec was having his amazing discussion, I was thinking to myself, man, it was so hectic, like probably we're solving the wrong problem. And so we went back at this initial case. Like, I think the problem is still, arthralgia and polyarthralgia. And, maybe we should have put more focus on that. I think if we step back too, we had this diffuse subacute inflammatory syndrome. And so endocarditis should have been invoked earlier on. So that's kind of a little bit of a cognitive autopsy for me in real time. But nonetheless, I think there's so much to take out of a response to steroids, and we could tackle that both ways. But I think what is needs explanation, regardless, is the positive blood cultures and the positive urine cultures. So this patient is infected with MRSA. There's really very little chance that this is contaminant. And so how does that play into this patient's clinical syndrome? So we already got the sort of alley-oop that we did an echocardiogram, and there was no signs of vegetations. And so just because you don't have the heart is but one source of endovascular infection. So the patient doesn't have a prior history of surgeries or other kind of foreign material in their body to suggest a deposition of MRSA. But are there sort of para-infectious or subacute inflammatory phenomenon that can happen with a endovascular infection? Sure. I mean, this is why there's subacute bacterial endocarditis and the sort of inflammatory features that can come with that. So the curious thing is we've been told that the patient's hip, previously there was no reports of that. Maybe, as Alec had alluded to before, the pain was just so prominent in the hands and the knees that it wasn't noticed. But now everything seems to have melted away, but the hip is really bothersome. So I'm worried that in the hip somewhere, the patient has a source of MRSA, and what that is yet to be determined. Maybe the patient has arthritis and degeneration of the joint related to being an outdoorsman and seeded the joint, developed the subacute inflammatory syndrome, which really wasn't defined by fever from the patient, but more of this prominent arthritis and the debility related to that. Understandably, they received some initial treatment because the antibacterials covered MRSA initially, but it will take time to kind of resolve the infection. The team was like, hey, I'm not exactly sure what's going on. Let's give some steroids. The patient improved. But as a sign of that, then we may have given us a clue as to the underlying etiology. So truly humbling, truly fascinating. I'd like to reflect on this a little bit more, but I'm going to give Alec some time to talk now.
Yeah, excellent. So I think I'm a hospitalist, and so I take care of MRSA bacteremia not infrequently. And I think the sort of degree of neutrophilic predominant inflammation, probably even with the odd time course, should have prioritized a pyogenic infection more, and endocarditis, like you have potentially mentioned. But then we can definitely explain the urine findings either from a GN activated from this infection, or just from the colonization of the tract or prostatitis or whatever from the MRSA itself. But I think astutely, always with Staph aureus in the blood, you need to know where it came from. Where did it start? Where has it gone? And it's very uncommon to seed multiple joints at one time. It can happen, but to have multiple hot red joints it seems a little bit odd. So I think I just keep going back to if any of the knee or if any of the elbow, if any of those had fluid to tap, I think it would be exceedingly helpful to do so, to know, as you can imagine, this is just a hyperinflammatory state with all the cytokines going on. Having an infection can predispose you to having crystalline arthritis, right? And Robbie talks about this all the time. When you tap the joint, you can have both gout and you can have both an infection, right? So, and then the sort of para-inflammatory phenomenon with Staph aureus, I think about it less compared to Streptococcus, for example, causing reactive arthritis. As far as I remember, there are case reports of Staph aureus causing reactive arthritis at the same time as an infection, but I've never personally seen it. So I wonder if there's multiple processes going on, or if this patient is unfortunately just exceedingly unlucky and had Staph aureus bacteremia. Not sure where it started from, and just went ahead and seeded multiple of the joints, though a bit odd. that the main reasons for presentation, which was like the wrist and the hand and the elbows and the knees, they got the steroids that went away, and then all of a sudden it was the hip that was hurting. And so certainly I agree with you entirely, Austin, that I think the hip for sure is very concerning. That septic arthritis has now involved now is there, or has just been unmasked by treatment of the other joint pain. And typically if you want to diagnose septic arthritis, you would just tap the joint. Sometimes with joints that are more difficult to tap compared to the knees, like I think the MRI is probably the best test. And if the patient, anybody with Staph aureus bacteremia, a lot of times in the hospital, patients are like, oh, I have a little bit of neck pain or a little bit of back pain. We sort of say, oh, you've been laying in the bed too long, or you worked really hard with PT yesterday. But anytime a patient with Staph aureus bacteremia tells you that you have pain, I have a very, 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 very low threshold to get scans for them, just because this bacteria will stick to anything and everything, and it's not something you want to miss. It will affect your treatment duration of antibiotics and potentially require surgical management. So just something that I'm thinking about as well. And there was a study, I can't remember exactly when it was, in the ER, I think it was like 2008 or something, where like they had a bunch of people that came in and they said they had bug bites or they had a spider bite. And it was like, I think over 30% of the patients actually had a Staph aureus infection. So I get a little bit hesitant when people are like, oh, tick bites, or I got bit by a mosquito or whatever. It's like, did you really? Or did you have something else? So I would love to know if this patient ever took pictures or what exactly was going on there, because that would be a potential entry site. And then I'm just really thinking about other risk factors, like going back to the history. Does the patient inject IV drugs that we were unaware of? Do they have any open wounds that we were not aware of either? Or does the patient have really bad onychomycosis or blisters on the feet because he hikes so much, or whatever else? And just trying to think about what predisposed this patient to have such a devastating bacterial infection. And trending the blood cultures will be appropriate to see how quickly they're clearing. The longer that you're positive in the blood, the more likely you are to be able to sort of seed the infection, or that can be a tip off that you haven't found all the metastatic sites of infection that you need to go about clearing. So, I think at this point, I'm really glad to know the TE was negative, but the hip is concerning. So if we're not able to tap it with the help of our orthopedic colleagues, certainly getting some additional imaging to clarify if there's a septic arthritis there would be important. And then I'm really trying to think about, are all these things related? And seemingly they're most likely to, but are these joint pains that got better with steroids? Was that just tamper down the inflammation and this was all infectious to begin with? Or is this joint pain that he was having a sort of a para-inflammatory phenomenon with the infection that has another etiology that we need to see? And I think the illness script that I was taught for Staph aureus bacteremia is like the patients are rip-roaringly febrile, they're always hypotensive, they always have a rip-roaring lactate, right? They take a while to get better. And I've honestly seen a wide spectrum of disease. I had a patient with like an epidural abscess that like never had a fever, but had very bad Staph aureus bacteremia. So it is an infection that continues to humble me to this day. And so, I would think with all these joint involvements, this is something that I don't typically see in Staph aureus bacteremia. And septic arthritis of multiple joints has been described, but it's just not that common. So I feel like it's just something that I'm unaware of, or there's multiple things going on that we're yet to elucidate. So I'm really excited to learn more what Kanish did. And then, just so we know, Kanish, how many more aliquots do you have left?
So we did after the patient complained of pain in hip, after an examination, we did an MRI and CT of abdomen. On MRI spine, we saw C4, C5 epidural abscess with L4, L5 osteomyelitis. And on CT abdomen, we saw bilateral psoas abscess. So we drained that abscess, we did a cultures on that, and it was MRSA positive. And it was kind of reactive arthritis from those staph toxins that was affecting his hands. And after draining that, we put the patient on long-term antibiotic, and after that it resolved, and we discharged that patient on long-term antibiotics.
Wow, incredible case. Thanks so much for sharing. So going back, was it thought that the patient, as Alec had alluded to, like the patient's tick bites or bug bites were actually like signs of portal of entry for the MRSA, or what was the thought of how the patient acquired this bacteria?
Earlier we thought that patient might have a Lyme arthritis, and we started patient on doxy and all that stuff, but his swelling was not getting improved, and he was like complaining of increased swelling. And one of our like residents said that, why don't we put the patient on steroid, let's see. And then we did, and it improved his swelling, and the inflammation was gone from his hands and his feet. And after that his hip started hurting, and that was the point we started to get an MRI on his hip and CT of his abdomen, and then we realized it's bilateral psoas abscess. That was the main culprit behind all this.
Yeah, well, thanks so much for sharing. And it's very tragic that the patient developed such a devastating and diffuse metastatic infection, but you guys were able to pick up on it, and it sounds like the patient recovered and did well. So hopefully they're back to hiking, and they'll probably take their each bug bite a little bit more seriously each time around. And I mean, I can't even recall how many bug bites I've gotten in my life, and this case will forever stick with me each time I pick at it. So, thanks so much for sharing. And yeah, my reflections. I mean, again, we started off, worried about an inflammatory diffuse syndrome that Alec alluded to nicely at the beginning, just with the profound nature of the debility that this condition was causing for the patient. And we talked about external infections versus like a worsening of a sort of a commensal organism coming in. And, we evoked the possibility of more atypical infections, but, I didn't explicitly state at all about MRSA. And, I think looking into the labs, the lab signature is really much more consistent with the subacute to chronic pyogenic infection. We're trying to kind of squeeze in the rickettsial infections and everything. Lyme has a relatively kind of unexciting labs. The rickettsial infections typically cause, leukopenia, thrombocytopenia. So, nothing's perfect, nothing's 100%, but we're trying to make it fit. And looking back, the tick bites, I did try to make the effort to discuss them, exclude them from the discussion, but I didn't explicitly mention it. So humbled by those things, more to learn, and definitely more. I'll definitely go back and rewatch this again to see where my reasoning went wrong. But I think what we did do well was understanding this was a diffuse syndrome. We were prioritizing infection, just given the patient's age, lack of other medical history, and sort of the more just subacute onset of it. And then it seems like the patient was inflamed everywhere. There's evidence in the kidney, the lung. I'm not sure if that ended up being like a septic emboli, or if there was just evidence of MRSA that had taken chop up in the lungs. And then, gosh, yeah, the patient's whole back was basically involved between the C spine and the L spine. Maybe the T spine got spared, but between psoas abscess, everything else. Again, I'm wondering too, maybe the steroid, I'm not sure how long the patient received steroids, but maybe that sort of tampered down the dramatic systemic response that maybe we would have seen just based off how diffuse this person's infection was, or maybe there was an underlying immunodeficiency that like we weren't aware of affected this presentation, and would also help explain like the patient's kind of pulse temperature dissociation that Alec alluded to before. But many reflections, and what a very, very fascinating and interesting case to think through. And Alec, what final reflections do you have?
No, wow, Connors, what an amazing case. I've never seen reactive arthritis with Staph aureus in particular. And it was just very hectic, just the hectic nature. And I think Austin, I think the profound neutrophilic leukocytosis really should have made us prioritize more, at least, or explicitly mention the sort of pyogenic infections. But if we're all being honest with one another, right? Like this patient came in with a febrile syndrome, which was most concerning for infection. We're all going to get blood cultures, right? And then within just a few hours with the PCR, you got to know what it is. You're going to know it's Staph aureus, right? But that just changes the way that you frame it. So I think maybe just sort of prioritizing the pyogenic infection earlier, just for this reasoning process, I think would be helpful. But in real life, that's something that you're going to know. And I think as well, though, if I was taking care of this patient, like would I have given a patient that was coming from the community like right away without a clear foci of infection vancomycin? And I guess it would really depend on how convinced I were these joints were septic arthritis, right? So that's an interesting point to think about. but I'll just tell you, like, I take care of Staph aureus bacteria all the time, and like every time I take care of it, something is different. And it's just exceedingly, it's an organism that we think we understand, but then just the presentations can be so incredibly varied depending on your host, depending on the site of entry, depending what organ systems get involved. And I think that's something that I'll just continue to take away and reflect upon that, to just consider a little bit more in all these patients, just because community rates of like Staph aureus acquisition are much higher than they used to be, and just can evolve anywhere and everywhere. So sort of I applaud your team, Connor, for really identifying all the metastatic sites of infection and getting the patient better. And yeah, I think it was humbling to know. And a lot of the psoas abscesses, I think about, anytime I see psoas abscesses, I often think about a GU site of infection that tracks its way up the Batson plexus in the veins, and they can go to the psoas muscles, or whether or not it just sort of is seeded from the adjacent osteomyelitis. And one of the we've had a case of that before, presented by Aaron Yang, or one of our residents here. But yeah, it's just a fascinating case. Always humble, a lot to reflect upon. And kind of before, do you have any additional reflections? And then after that, we can get it to Kashar for the teaching points. Okay, awesome. Well, Connor, thanks so much for presenting. Learned a lot. Kashar, take us away.
Thank you.
All right. Thank you for the great discussion, and thank you so much for the great case. It was a twisting and turning case, honestly, with a lot of signals we didn't initially know what to do with, and it all came down to a single point. I tried to summarize as much of it as I could. The case initially started with a diffuse and unspecific syndrome, inflammatory syndrome. Our initial questions was this an acute phase, or we were trying to establish the timing of the case. And as the case further went on, we established a subacuity in the case. Then we started to focusing on the complaints. Where do we want to tackle first? We have fever, we have joint pains, and with the joint pains, our initial approach was articular versus prearticular versus muscular. In these cases, always physical examination comes to our aid here, with prearticular causes causing restriction in movement, usually only in one direction, and with active motion being more restricted than passive motion, versus the articular problems in which restriction is seen in all ranges of motion, and both passive and active motions are restricted. After establishing our initial approach, we started approaching the tick bite history in this patient. It is a big picture here. It introduces a lot of differentials into our diagnosis, but we have to separate the signal from the noise here. Do we tackle this tick bite initially as the causative event, or is it a bystander here? The tick bite here could point to many things, and for filtering all of those, we gotta examine the lungs, the liver, we gotta examine the skin, look for rashes, look for hepatosplenomegaly, and all of those to establish a tick-borne infection. Here, an interesting sign that really helps us is the heart rate and temperature mismatch. We expect the temperature to rise as we expect the heart rate to rise as the temperature rises. If it doesn't, it's called a Faggot sign. And after ruling out non-infectious causes, both tick-borne organisms and gram-negative bacteria are very specific for this sign. So this again moved us even closer to a tick-borne illness here. And so with that in mind, we approached the labs. There were many mismatching labs here and there. We couldn't really put the picture together. We started thinking about what could cause lung and kidney involvement. And with Lyme disease being a really big cause from the beginning, I put some teaching points here from the chat that people mentioned, especially Hemoon. We can stage the Lyme disease to an early localized stage up to the first months, which can present with erythema, flu-like symptoms, eye redness, and 30% of the patients are asymptomatic. After that, we get to the early stages. We have VVC fever, malaise, joint pain, CNS cardiac involvement, Bell's palsy, and other signs, until late signs, which present months to years later, presenting with arthritis, cognitive deficits, and radicular pain, and other signs. With all of this coming together, we reached the final diagnostic point of blood cultures and urine cultures here, which pointed us to a MRSA positive culture. The most important part about approaching MRSA case, MRSA bacteremia, is to understand where did it come and where did it go. It disseminates and can come from many places. We usually can frame the patients as clearly as we can with many other infections. Especially in this case, an interesting point for me was that probably the tick bite here was the point of entry for the MRSA. I hope I've been able to capture as much of the teachings as possible. Thank you for the great discussion on the case.
As Reza would say, awesome, Kashir Jan. Thank you so much. And thanks again for joining, having us. Connors, thank you again so much for presenting this amazing case. And then David, thank you again for prescribing. And you know, I think there's another CP Solvers case tonight. Please mark your calendars and join us. And yeah, have a great day. Bye-bye.
Thank you.